So good evening. You're very welcome to the University of Warwick, the MSc in Diabetes Care webinar. We're very pleased to have you here with us. We'll try and keep this webinar to within 1 hour. So we will run a few presentations for you for the running order for today. So we'll start with Dr. Ralph Odom down in Oz. He's a GP in Australia, and he's also the director of the Primary Care Diabetes Society of Australia. And then we have one existing student from Australia on the programme, and hopefully she will be having a quick chat with Diarmuid about her own experience. There she is, there's Jackie, we'll admit her now. And so we'll just get her view as a student and participant on the programme and as a very busy clinician. And I will then just give you a quick running order of essentially the programme, the curriculum, the pricing, what to expect, and the general layout of the programme. And then in the end, we'll open to Q&A. Just to let you know that you can't share screen, you can't unmute, and the only real way you can communicate with us is through chat. That is for ambient noise reasons and also for security purposes. So you can't annotate or anything like that. So the only way to interact with us is by chat. And you're very welcome if you have a question in the middle of the presentations, you're very welcome to make that question anytime you want, because we've plenty of our team with you online here today who can answer your questions in real time. But we will be open to throwing it open to the floor for a full Q&A for the last 10-15 minutes. So you can save your questions or ask them as soon as they come to mind, whichever you prefer. Just one other little bit of housekeeping. If you do have an unidentifiable name like iPhone or Galaxy or something like that as your Zoom name, one of our staff will be reaching out to you privately to ask you what your real name is, so we can make sure that you're ticked correctly as an attendee at the webinar, and that you get the right communications after this event. So without any further ado, I'm going to hand you over to Dr. Ralph Odom to begin his presentation.
Okay, now I'll need to be able to share my screen.
Oh yeah, hang on, sorry Ralph.
Now Ralph, you're a co-host now, you should be able to share your screen.
Okay, there we go. So, hello one and all. So, yeah, my name is Dr. Ralph Odom. I'm a GP from Carlton. And what I thought I might do is just talk a little bit about quality improvement. The reason why I've picked that topic is because it's, for me, one of the reasons why I get involved in education, tertiary education and teaching. And I suppose I would hope many of you joining this program are doing it because you want to see things improve. Now, what I'll do is I'll start with, to me, data is really important. Now, this is a group of practices in Australia. And what we thought we'd do is, we'd look at how they were going with their practices. But very interesting, the very first thing that came up to me was, in fact, yes, they have 2,500 people with type 2 diabetes, but a lot of them haven't actually been categorized. They're actually undefined. So we don't know whether they're type 1, type 2, gestational. And so if they don't know that, it actually makes it really hard for them to work out what to do. And so, one of the things we really want people to be is actually exacting around their data and have clean data so that they can work with that data. The other thing that really surprised me was the low rate of type 2 diabetes within their practices. Now, people attending a general practice, I would expect far more than the background that I would find within our population. And so here we have really quite a low percentage of of people attending this practice having type 2 diabetes. And so then you'll start thinking, well, have they coded it? Are they capturing it? Because at the end of the day, if you want to know how you're going with your managing your people with diabetes, you've got to have them captured. And so we then did a search on things like people who are on metformin, people who are on diabetes drugs. And sure enough, there's another 1,800 people that are on this medication, but do not actually have diabetes within their past history. So, in terms of data, it just tells me, we've still got a lot of work to do in practices. And as you know, you can see now I'm really driven by data. I love data. This is Australian data of what we call an annual cycle of care. So GPs get paid an extra amount of money to do an annual cycle of care. Well, they used to anyway. And then we used to put in an item number. And completing that annual cycle of care, it was really what I call the minimum amount of services that you would give people with diabetes every year. And you can see only about 10% of people actually ever had it claimed. Now, yes, a lot of them will be because people aren't claiming them. But again, to me, it was an easy way of working with doctors and practices around identifying people and actually having a simple measure, engaging how they were managing their patients. So again, it's really all about that thinking. And what I would hope is that when you attend these sort of courses, you think a little bit outside the square. You think about, well, what can I do with this knowledge? Because we don't want to teach you just to be more knowledgeable. We want you to be change leaders. And another thing that we often do is what we call medication reviews. We know medication reviews are really important for people with type 2 diabetes. They help lower A1C because they're on so many medications. And again, in this particular group of practices, very few people actually got that. So, and that sort of came on, time and time again. So, we know that there is a gap, and look, that is international. So one of the things I like is about is quality improvement, because you can't change everything all at once. And so you focus on small things as you go along. And of course, what the course will actually take you through various aspects of diabetes care. And what we would hope is that you would then get a passion for making change. So we often talk about all the different domains of quality improvement, but really this is what we're after. We want to improve, patient experience and outcomes. We want it to be sustainable. We want it to have an impact at the population level. That second one, the improved provider experience, only came in recently. It wasn't, until then they didn't really care about how we felt as clinicians. But you can see that they've added in because it is important. And when you do this work, you do get a sense of doing good and feeling well. And so when we look at a quality improvement, you try and click on all those, boxes, and it tends to work. And so, as you know, I am a data man. I think data speaks volume. When you talk to health professionals about how they manage, they will always tell you they are going well. When you give them their data, the very first thing they say is, I don't believe it. And I think this is really important because we have a sense of good cases, but we often don't remember some of the ones maybe that that are a bit more challenging or that we don't see as often. And really what we want to do is give you the tools to be able to manage people well across the whole board. And so hence, the cleaning data. But if you can't measure what you're going to do, it then becomes really hard to actually then obviously do improvement. So again, if you do the course, the information they give you, it will give you a lot of things to think about what you can do within your actual, where you're working within your practice, within your, health service. So if you can get data, what you do is you want to look at what sort of data that you can get easily, and then look at it and see whether you are happy with it. So in Australia, I know roughly about 50% of people have an A1C less than 7, but there are still 20-30% of people have an A1C greater than 8. It's clearly not acceptable. So again, you look at your practice and you start to say, well, look, I'm not happy with this group of people above 8%. What am I going to do about it? Now, you can cut the data any way you like. You can look at the medications they're on, how often they're being seen, what sort of lifestyle, education they have. And again, with the course, because as I've actually gone through the whole lot of it, they actually talk all about the different areas that you can do to actually make an improvement in people, your management, your approach to people with diabetes. But once you have that knowledge, it's really about trying to do something with it. And really, I'd really encourage you to do that, because it will enthuse you, and might then, I'm sure Dermot would love to hear this, get you into doing a master's later on where you can do a research project on it, because, this can lead on to other quality improvement. But the biggest mistake that I see time and time again is people trying to do everything at once. So again, as you're learning things, as you're going through the course, pick something that you're passionate about, but pick something that you can actually achieve within a reasonably short space of time. Because if you start with a small intervention and you can see the impact that it has, it will then get you to doing other things. And of course, you build up, and then with time, you will actually make sustainable changes and have a really big impact on a lot of your patients. So really, you don't eat it all at once, it's bit by bit. And a lot of people who've done collaboratives and quality improvement will recognize this diagram. It's just a simple approach to how to implement quality improvement, with any system. So you can always use it no matter where you work. And it's actually a really good thing as you go through what it is actually trying to do, how you're going to measure it, and then, all the little plans that you can actually do. So, I'm lucky that I have a team around me, and I'm sure, many of you will also have a team. And, one of the hard things is actually making sure you engage with the team. So if you do have an idea, it's hard to do it on your own. You've got to really then think within your health service, who can you bring in who might have an interest and actually want to do an improvement like this? And then, often if you get an enthusiastic team and they get early wins, it will build a life of its own. And, because once people see things and do things that are, in incremental steps, but they're winning, they want to do more and more because they start to see the impact of what you're doing. And this one I think is really important. If you do an intervention and you do see it improve, you need to tell everyone. You need to put it up, in newsletters around your service. You need to, present it at, grand rounds or whatever, but tell people what you've done and how you've done it, and share it with the world. Because, if you do that, other people will start sharing with you their sort of things that they've done. So again, just going right down to the basics, when you're doing a course like this, you will have a huge amount of information thrown at you. What I would encourage you is to actually reflect on your own practice and think, yeah, look at where you think the gaps are. Think about what it is that you might be able to do that will make a change or an impact on the people that you're looking after. Because, if we get you doing things in a sustainable way that makes a difference, again, it is something that will spread, other people will notice, other people will take it on board, and so it goes. So do reflect on, what is that what data you can look in your health service, what sort of goals you might be wanting to achieve, what changes you could make, what sort of measurements, because you need to be able to find measurements that you can get easily. And then the with me, it's what's in it for me. It's got to make your job, more satisfied, hopefully easier, because you start to streamline things. But, if it's going to be a burden for you, it will never be sustainable. Share the data. So if you have a team, share the data, because that will enthuse them to make a change. Because people often don't like, if they see that there is a gap, most health professionals want to go in and make it better. So control that enthusiasm, start small, work big. Now, I know I'm asking a lot of you, because I'm asking you to actually be change leaders, but that's what education does to you. It empowers you to see something, make a change, and then follow it. And it's that rigor that I would really like you to, again, reflect on while you're doing the course, if you decide to do the course. Always think after you've done the intervention, did you actually achieve what you wanted to achieve? Which things worked better, what other things didn't work so well, learn from them. So when you do your next intervention, you learn from that, and then think about those critical success steps. So, I would encourage you again, when you do the course, or if you are going to do the course, please reflect. We do have open forums, and I'd love to hear some of the ideas that you guys come up with, and challenge us if you think we're short on something. But please, your patients, we know, diabetes management needs to be improved, needs to be sustainable, and it falls on people like you who have an interest, who are willing to put time aside, that will actually make a large difference. So one of the topics that I talk is really about patient empowerment. Now, I'm only given 15 minutes. I could talk about this all day because I think it's really important. And I think the module that we have is really interesting because we actually bring in a whole lot of motivational interviewing, individualization of care. I'm sorry, I had to put that in only because I love it so much. And to me, if you have an activated group of people that you're working with, it is so fun. And I support a lot of diabetes support groups in and around Melbourne. And I just love giving talks to them and interacting with them, and, improving their self-efficacy. But, there are lots of tools out there, that you can use to help you if you decide to do or make a change, even within your own, the way you do things or within your service. And, if you're in a large service, often quality improvement is considered to be an important part of what they do. And, I gave you that example at the very beginning. Clean data is really, really important. There should not be, people with just diabetes as a diagnosis. They need to have type 1, type 2, gestational, or then you got some of your rarer, more specific ones. And again, that's what we're currently working on with that group of practices, because again, this is critical when you're handing over letters or talking to people or planning an intervention. And look at the goal. There's always got to be challenging, but we want to have 0 patients who just have diabetes and nothing else beside it. So I've tried to go really quick because I only had 15 minutes and I had, more than 15 slides. But I hope you've sort of got a little bit of my passion around how important it is that we as clinicians, the role that we have in improving the outcomes for people with diabetes. And if we don't do it, who is? Yeah. Thank you.
Brilliant, Ralph. Absolutely brilliant. I could not agree more. And I think one of the things that people will see when they come onto the course is that it's a university qualification, which means by its nature, it has a level of academic rigor to it, but it's a really deeply applied course. What we want to do is have people that come off the course with a huge degree more confidence in how they're going to manage their patients with diabetes. That, my cat has typically decided to join us.
I thought it was your baby.
It's the cat. But it's things around, to kind of expand on from your point there about data, having patient registries, having really active, really, again, properly documented patient registries, so you know whose door you need to go knocking on to get them to engage. It's having all those systems in place. And as you'll see when Rebecca brings us through the course, everyone, that is one small aspect of a very comprehensive course, but it's a really good example of how you can use kind of the latest thinking and use an evidence base to make quite practical changes that actually can have a really big impact. And throughout the program, you'll see everything about the various treatments and how to manage complications, but threaded throughout the whole of the program is, if you can get most of your type 2 patients on board and empowered to make lifestyle changes, you can mitigate a whole lot of risk for them. You can make their quality of life better. And our program leader, Colin Kenny, he'd often say, we're not adding years to life, we're adding life to years. You can really improve quality of life for people. And what this course tries to do is give you that toolkit to draw from. Everybody in this program is going to have a different type of practice, a different perspective, different scopes of care, different facilities available to them. But the common piece is, as Ralph said, you can look at the team you have, you can look at what you have available to you, and you can make a real and lasting impact on your patient care. Is Jacqueline on, actually? Can we have Jacqueline, do you want to say hi to the group?
Yeah, sure.
How you doing?
Hi, can you hear me okay there?
Yeah, absolutely perfectly.
Yeah.
Do you want to just introduce yourself and give a little background as to what you've been doing with us for the last while?
Yeah, sure. So I'm a GP in Merimbula, which is on the far south coast of New South Wales. So I've been a GP for 7 years, and I'm a GP obstetrician as well. So I guess my reasoning for joining the course was I felt like I was drowning in lifestyle disease in my practice, and I really wanted to get better at what I was doing for my patients. And also with my gestational diabetic patients, once they're on insulin, they have to travel to our nearest city, which is about 3 hours drive away. And so I was losing all of these women to the city, and I was thinking about gestational diabetes and how I could improve things. And then, I saw the course pop up, and I'm actually in the middle of my maternity leave and transitioning back to work. So I joined it at a moment where I thought I could do everything, a little bit like Ralph was saying about too much motivation and not enough hours in the day. But I've managed, I've really enjoyed the course. I think it's really well structured, and for someone that's working or time poor, I think it's really flexible, where you can, I often do my work late at night and manage it around my family. And I've really enjoyed the tutorials. We have ours on a Friday night, and we've started a WhatsApp group with, I've made some friends in Malaysia and some contacts in Townsville. So I've really enjoyed the friendships that I've made as well. So
I think that's a hugely important part of it, is that sense of community. And particularly family doctors can, very often it's a solo run. You are a sole practitioner, and even if you're leading a team, there can definitely be a sense of I'm in this on my own a lot of the time. And I think that camaraderie is hugely important. And what you spoke to there about kind of flexibility and the course being kind of designed so that people can do it. Everybody on this program is a practicing clinician on a full-time basis and studying on a part-time basis, and some are as insane as you and juggling young families. But it should be possible. I mean, you're about at the halfway point now on it. I mean, have you found it's changed how you're practicing?
It has. I think with the confidence that Dr. Ralph was speaking about, I mean, just thinking of really small things, I think in my practice, I've given a few education sessions just on some of the medications and some of the things I've been learning to the registrars. So I felt a bit more confident to do a bit more medical education. And my girlfriend and I in our town, we've got together and we've formed a mothers and kids soccer like kick around to try and get mums and babies to be more active. So I probably wouldn't have been inspired to do that, but I was thinking about trying to make my community more active. And so my friend and I have started doing that. So, I guess, you do build a bit of confidence to try out a few new skills. Yeah.
I mean, it's so you've been a GP for 7 years, which means it's been a while since you've done things like essays or the kind of the study part of it. How have you found transitioning back into that?
I think this is a perfect stepping stone, because I must admit my hesitation with joining was about my literacy, my written skills, and my ability to critically appraise data. And I think it's a really great, it's just the perfect level for where I'm at, you know, I think. And, you know, we've received really good feedback on our essays. So I've found, yeah, really good. Yeah.
And I think that those two words, critically appraise, are probably at the heart of a lot of the program. I mean, and to Ralph's point, you know, if you have data in front of you, be it data from your own practice, be it that you're looking at the outcome of a clinical trial or you're reading a research paper, what we want you to do by the end of the program is not need somebody else to interpret that for you. It's to be able to look at the data, to, you know, look at the context of it, the quality of it, and make a really informed judgment on it, and then see how useful it is in your context. And that, you know, it's almost hard to see that as you go through it. It's usually, you know, when you look back a year later after a program and kind of reflect and go, wow, yeah, I wasn't anywhere close to the level that I am now. And, you know, that's a skill that takes you, you know, that's relevant to any clinical context. And I think the other one that, and what you were saying about, you know, drowning in lifestyle health issues in your clinic is, I think a lot of the chronic care model that in this context we're teaching you about diabetes, but, you know, that's going to be as relevant to people that have COPD or, you know, anything else. It's really, you know, how do you structure care to manage chronic diseases is, I think it's hugely important. Right, Jackie, I am conscious that we could natter all day like Ralph. Rebecca, will we kick over to you to give the actual structure of the program and the presentation? And if people want to, there's a couple of questions coming in on chat. I'll happily start responding to them. If people have more questions as this goes along, we'll respond on chat, no problem. And yeah, then obviously take kind of free sessions at the end.
Sorry guys, I'll just
questions at the end. Sorry.
Why have I just stop for a second?
Yeah, that looks midway through.
It does for some reason. No. No. How's that?
Brilliant.
You can see that? Great. Hi everyone. So I'm just going to give you an overall view of the structure of the program, and just very important on pricing and what to expect in terms of workload, etc. So I know we're under a little bit of time pressure. I don't want to keep you above the hour because I know you're very busy clinicians. So I'll talk fast and boot through this if you don't mind. So when you hear about this MSc in Diabetes Care from the University of Warwick, you will also hear about IHEED. And you'll hear IHEED and the University of Warwick used interchangeably. So who are IHEED? First and foremost, we're an OPM, which is an online program management company. And we essentially put curriculum from universities and world-leading medical universities and postgraduate training bodies in an online environment. And I suppose we deliver online medical education across the globe. We serve governments and healthcare ministries internationally. We have large MOUs with ministries of health across the globe, particularly in the Middle East and Malaysia, for example, and in Singapore as well. And you may not have heard of us, but we do have a large global footprint. A lot of OPMs, online program management companies, they deal in every single subject area. So they're online education providers, but we are healthcare specialists. We're formed by GPs, established by GPs, and we have a large amount of clinicians on our team. We're very happy, and subject matter experts from around the globe on all of our disease verticals. So we are very much healthcare specialists and only provide online education in the medical education sphere and medical education vertical. And we have over 300,000 course completions to date on the IHEED platform, and around 30,000 clinicians registered on IHEED programs across the globe. So you may not have heard of us, but we do actually have a large global footprint. So we are the online program management company for the University of Warwick Medical School. And the University of Warwick is a top 10 UK university in the QS rankings. They're 62nd in the world rankings in QS. They've educated over 14,000 clinicians in the United Kingdom in diabetes management and upskilling. So they actually have an excellent recognition and, I suppose, reputation in terms of diabetes education. They're a member of the Russell Group, and the Russell Group are the top 30 UK universities, and they're very research intensive. So they're essentially the Ivy League of the United Kingdom. World leaders in diabetes education, as I said, and they fully accredit the IHEED programs. So that means that you are getting your university certificate directly from the University of Warwick. Nowhere on your certificate does it say blended or distance or online learning. You get the exact same qualification as if you flew to the United Kingdom and did the qualification in a face-to-face environment. So there's no negativity, or there's no reason or no differential between the online and the face-to-face qualification. So just before I actually go into telling you a little bit about the program, you might wonder, God, there's exemplary Australian universities with world ranking, very high in the world rankings. So why is a United Kingdom qualification having a base or having a cohort of Australian students? Well, actually, what happened is we have a huge, I suppose, wonderful reputation and a lot of partnerships in Malaysia and in Japan. And when we were promoting the program across the globe, we have around 300 registrants per annum. And we started getting organic queries from Australian clinicians. And they started registering out of the blue. So we investigated, and there are exemplary diabetes educator programs in Australia in almost every university, but actually in terms of masters and postgraduate qualifications that are entirely IPE, which is interprofessional, there aren't any. So as Ralph mentioned, it is all about the team, and we pride ourselves, and it's part of our social mission, to upskill the entire multidisciplinary team together, because that's the best practice in terms of tackling NCDs. And so on our programs, we have doctors, we have nurses, we have pharmacists, we have endocrinologists, we have cardiologists, we have dietitians, we have podiatrists. So everybody in the whole multidisciplinary transmural care team, from tertiary right through to primary, are involved in the management of diabetes, and to upskill collectively and understand the, I suppose, importance of every single team member in that role really has better patient outcomes. So we're very proud of that. And I think that's one of the reasons why the program is doing so well in Australia, also because the level of remote care in Australia, such a huge country, the fact that it's online, and it wasn't just thrown online because of COVID. It has been, we launched this program in 2016, spent over €500,000 in creation of this program. So a lot of thought and care and love has gone into the curriculum to deliver it in an online setting. So just go into the details of the program. You commence with the Postgraduate Diploma, which is a 12-month program. And then if you're not sick of us by then and you want to progress, you can go on to the Master of Science after that. So it's entirely part-time, and we have our face-to-face Zoom tutorials every week at a time that is suitable for the local cohort. So as I said, we have around 300 registrants every year from across the globe, but don't be worried, we don't throw you into a class of 300 students. We divide the cohorts, and there's never any more than 30 in your particular group. And we divide them by time zones. So usually in Australia, the Australian, Malaysian and Japanese cohorts are together. And this is a time, and the tutorials are at a time that is suitable for the majority of the clinicians. So as I said, it's full international accreditation by the University of Warwick, and delivered in partnership with the Primary Care Diabetes Society of Australia, of which Ralph is the director, and currently undergoing recognition by the RACGP as we speak. It's designed and delivered by world-leading diabetes experts, and we're not one of those institutions that think one size fits all. In every single jurisdiction and geography that we teach this program, we combine the learnings and the tutors with local experts like Ralph, and then international experts from around the globe, from Europe, the Middle East, from Malaysia, from the States, from all over. The tutors are cherry-picked because they are leading KOLs in diabetes management. And it's delivered on the world's most advanced medical education platform. When I first saw that sentence, and I've said this on multiple occasions, it was a bit mortifying. I was like, oh God, boast much. But actually, I've had 20 years in tertiary education, and I've seen a lot of online programs and how they're delivered. And this really is so far removed from that terrible traditional distance learning that gave distance learning a bad name. And when I'm talking about those boring downloadable PDFs, and talking head videos, no interaction, we are at the total different sphere from that. We have 3D videos, interactive quizzes, we've hot topics, we have the Zoom session every week. The students are not left isolated, they're not left alone to study remotely without the assistance of our team. So there's an awful lot of touch points, there's a lot of collegiality. And just the innovation on the learning management system makes sure that you just feel like you're part of a cohort and a collegiate environment. And the way that the program is developed online ensures that you can engage with very complex topics in a very palatable format. So it really is a wonderful, wonderful. If we have time, Dermot might be able to show you a bit of the platform. So just to give you the example of the internet. Sorry, Dermot?
I was just going to say, Rebecca, I think it's important to say as well, this webinar session is very much content at you. What you'll probably have gotten from the way that myself and Jackie were talking is when you're on a tutorial, it's not a lecture kind of giving you a didactic session. It is a back and forth facilitated conversation. It's, the whole premise of the program is to get you to benefit, yes, from your tutor, but also from your peers. And some of what Jackie was saying about, having friendships in Malaysia and Townsville, as well as where she's from in Australia, that element of kind of peer-to-peer support is really important in the program. Sorry, Rebecca, go on.
No problem. I think one of the beauties of the partnership between Warwick and IHEED is that we don't have to just hire Warwick professors. We can cherry pick from the very best opinion leaders across the globe that are immersed in diabetes and really have a passion for better patient outcomes across the globe. And that's what we've done. And that's reflected in our tutor group. So this is just a sample of some of the tutors that you'd have. So Dr. Colin Kenny, he's our program director, and he's Royal College of General Practitioners examiner, and he's the past chair of the Primary Care Diabetes Society in the UK. Dr. Pam Brown, she's editor-in-chief of Diabetes and Primary Care Journal and a member of the NICE Guidelines Committee. Katie Reid is University of Manchester, a clinical education expert and an expert in clinical or behavioural change in a clinical environment. Dr. Martin Hadley-Brown, he's from Cambridge University, and he's a founding member of the Primary Care Diabetes Society and a member of the NICE Type 2 Diabetes Guidelines Group from 2008 to 10, and a clinical advisor for the RCGP. And Ralph, as he's already had the introduction, and he's the director of the Primary Care Diabetes Society in Australia, a GP in Melbourne, and a clinical associate professor of the University of Melbourne as well. So it's a wonderful mix of international and local tutors, which we're adding to all the time. So what does it mean for you? As I said, we've small group participation, even though we've large and enthusiastic cohort of around 300 across the globe. We usually have small groups of 20 to 30 maximum. So you will only know your own group. They become very close. The clinicians often set up their own WhatsApp groups and talk freely amongst themselves on patient cases and on a more social basis. We have 6x6 week modules, and they're well placed, and there's a flexible structure. You have 2 weeks break in between each module, and we also break for local holidays as well. There's a personal commitment, and I say 10 to 15 hours here. And when I say this in a live environment, I hear this huge audible gasp from across the room and a few chuckles. And I'm sure Jackie is chuckling away, because that's not a reality. That doesn't happen.
No.
Realistically, if it's 3 to 4 hours a week, and there will be more when it's coming up to your essays submission and also for your examinations. So don't panic. that's what we say it should be, but that's not.
Yeah.
In order to excel on the program, 3 to 4 hours a week is definitely sufficient in combination with your live tutorial. And then strong individual support, as I said already. We have a huge amount of touch points. We have a wonderful team in IHE that make sure our mentors and our academic affairs team make sure that you're definitely not a number, you are a name. They get to know you very well. And because it's an online environment, the beauty of that is that we have advanced analytics, and we can tell if there's a clinician on the program that's falling below the mean average of engagement on the program. So if they don't have enough page views, they're not attending the tutorials, they're just not engaging, they can be red flagged on our system, and we will actively and proactively reach out to them to make sure they're okay. And that's something you just can't do in a face-to-face university setting. So this is the advantage of online, to really make sure that you're engaging and you're looked after. If you're struggling in any way, we can just pinpoint people who have issues. So the actual curriculum and the program structure, each module, these are the first 3 modules. The first is core principles of diabetes, and it's very much mirroring what Ralph already spoke about this morning. Data is everything, and if there's the 20-30% of your HbA1c group that are above 8, you know, it's about looking at that. It's like diagnosis screening. How can you be proactive rather than reactive, and really engage with the data, and I suppose put in place best practice in terms of pre-diabetes, prevention, screening, classification. So that's how we start the program, and epidemiology, of course. The next is treatment and medicinal interventions. Once upon a time, it was metformin, and lifestyle change was the one-size-fits-all approach to diabetes, to type 2. And now there's so many injectables and orals available across the globe, and one size categorically does not fit all. And it's all about individualization and looking after that particular patient who may have underlying comorbidities, multimorbidities, and looking at them. And we work through the treatments all the way through the more advanced and severe treatments of surgery and diabetes in adolescents and children. So that's an intensive module. We then move on to self-management, and that's one that is close to Ralph's heart as well. And I think that's one of the modules that when we have we do a questionnaire at the end of each semester with the students on the program. And that's one that gets a lot of very positive feedback in terms of behavioral change and patient empowerment. There's 8,800 hours in the year, and a patient may have 3 or 4 hours with their clinician. So they're left alone very much to manage their own disease by themselves. And within the NHS, there's a motto, no decision about me without me. And that's very much, I suppose, explained in this module. And you're looking at your motivational interviews and how to really get the individual to take, I suppose, responsibility for their own condition and embrace how they can improve their own outcomes. And you are just helping them and guiding them and steering them using motivational interviews to try and just get those better outcomes. So I think that the clinicians and the participants on the program really do like that module. They find it they can implement it very quickly into their practice with good outcomes. Next, the last 3 modules in the second semester, we go into microvascular, the complications, microvascular and macrovascular complications. We do an awful lot on how to conduct a good foot examination, for example, your retinopathy scans, nephropathy, and then, of course, a macrovascular CVD, etc. So they're both very intensive modules. And then we finish off with special circumstances, our last and final module, and that can vary a little bit in terms of the jurisdictions that we're in. For example, when we teach in the Middle East, we would put a lot of emphasis on Ramadan and Hajj. Any type of religious fasting can, of course, lead to both hypo and hyper glycemia, so you have to be very careful there. But as Jackie was talking about gestational diabetes, family planning with type 2 patient. All of that is just so relevant and serious in terms of fetal macrosomia and just the outcomes of an expectant mother and how to make sure that the glucose levels are kept in check. So it's just very, very, very important module, and it captures all of the elements that really we've been talking about in the last previous module, 5 modules.
What I was going to highlight there, Rebecca, was that what you can see throughout that spread of modules, going from kind of core principles around things like screening and diagnosis, and people that are in a pre-diabetes state, which is, and then moving to treatment and self-management, and then on to the complication. You're following the patient journey, but it's also, this curriculum has been designed both to be an online curriculum from the outset, but also it's in line with the International Diabetes Federation's guidance on what a postgraduate qualification in diabetes should be covering. So it's that flow and structure works really, really well.
Thanks, Dermot. So if you are still willing to study after 12 months and you aren't sick to the teeth of study and juggling busy work and family commitments, you can progress onto the MSc, the Master of Science section of the programme. That is takes around 12 months, 8 to 10 months really on average for the student to do on top of the PG dip. So it's divided really into 2 modules. The first is deciding on your own idea, your own project. So you choose a research idea, you review the literature, you outline and design the outline, design and methodology, you develop a research proposal, you collect your data, you analyze your data, you get your ethics approval, and then you write your paper. And then, one of how this differentiates this MSc in terms of other master's programs across other universities is that it's very pragmatic, it's very practical, and we're excited about the output from this master's. It's not a 30,000 word thesis that sits on a dusty shelf and is never read again. Our output from this, and what we ask, is a 4,000 research article in the style of the ADA, and with the expectation that you would be published in either a local or an international medical journal of repute, and you also must have a conference poster presentation. Obviously, in our new reality right now, that would be a virtual medical conference rather than a face-to-face conference that you'd be creating that poster for.
But again, in keeping with the practical applied nature of the program, we want the output of the MSc to be something that will actually have utility for you. And some of our MSc students are doing absolutely fascinating studies that they're definitely going to be published. So it's a brilliant way of bringing yourself into a deeper understanding of research methods and publication. It's also, again, it's another transferable skill that'll be with you for your whole career, but it also gives back to the body of knowledge in diabetes. And, we have participants who, if someone's doing a study on a rural population in, be it Malaysia or be it Australia, the literature is needing that type of work to be done. So it's a fantastic way to give back to the diabetes scientific community. As well as get an MSc.
I suppose that it's echoing what Ralph said. It's about if you learn something, celebrate it. If you have an impact, celebrate it, tell the world, and that's what this applied output is doing. And also from a more individual perspective, if you're a published researcher in the area of diabetes, it can also help your own CV and your own personal biog as well. So how does it work? We commence the program on the 29th of November, and that will be the orientation week. And so that's a full immersive orientation where you will just get to be comfortable on the platform. You'll understand how to reference correctly, and just getting back an awful lot of our participants, maybe 15, 20 years out of formal education. So it's getting you comfortable being back in that environment before you kick off on the program a week later. So in terms of what we do in a weekly, basis, the tutor will give out a particular discussion topic that will cover the learning outcomes for that week, and they will give that in the online forum, and a link to all of your reading materials as well in the learning management system. And so in that discussion forum, we ask all of the participants to participate in that forum, and once again it's discursive, it's discussing amongst yourself, and it's just moderated by the tutor. It's not didactic in any way. And that the forum is then culminating at the end of the week with the live weekly Zoom tutorial, where you'll discuss the forum, everything you've talked about and your learning outcomes in a scenario basis. In terms of everything we do is applied. We talk about very specific cases that will cover your learnings for that week in a very applied scenario. So essentially you're talking about an individual with HbA1c and blood pressure, comorbidities, etc., and you will cover exactly what you need to cover using particular case-based scenarios. We also have, in terms of, we have continuous assessments, are that we have a 2,000-word essay that you at the end of each module, and then we have end of semester examinations that are also given in an online environment. So we use online proctoring. You can do it in the comfort of your own home, and you may ask, how can that stand up to the academic rigor of a university examination? It absolutely can. We have individual examiners in the online proctoring system that actually supervise you doing your exams. You scan your camera around the room and under the desk, etc., and they watch you. And if there's any unusual activity, they will flag that. So you can do it and the online exams from the comfort of your own home as well.
I think it's important to say there, Rebecca, as well, that the exam, actually most of the marks on the program go for the essays. And I think that's right. What we want you to be able to do is to kind of critique the literature and apply that to your own scenario. The exam is necessary, but it's only worth about 30% of the marks, whereas most of it is the essay that you do in your own time, and actually there's always a better opportunity to display an intensity of understanding in a kind of a piece of critical appraisal that you do of something than in the online exam. But yeah, again, the assessment strategy works really well for the type of audience that we have.
So this is an example of the learning and environment. As you can see, there's a lot of imagery, a lot of video, a lot of case-based and scenario-based education, as I said already. So it's a very palatable and very engaging and easy to navigate. We have key opinion leader videos as well. There's Dr. Mohammed Fargley, who's head of Diabetes Society in the UAE, in the GCC region. That's an example of one of our Zoom tutorials that happens every week. If you can't make that tutorial for whatever reason, it is recorded, so you can go back in and look at it if you're too busy with clinics or in shift work. So this is an alumni feedback in terms of 3 years after the program, the impact of the diabetes program for that individual. And I think this is a wonderful graph. It shows in terms of the large positive impact and quality of patient care before and after the program. You can see there's a large positive impact. There's some positive impact in terms of your career, the reputation with colleagues. And this is a big one as well in terms of understanding research papers, clinical trials, etc. The confidence of clinicians of understanding those scientific research papers is hugely enhanced as well. So the impact of the program 3 years out, you can just see it's really beneficial. So the administration and support, as I've touched on this already, you have your program leader and your tutor network, and you'll be very integrated and get to know your tutors very well. But also there's the mentors and the supervisors that will make sure, as I said, that you don't study and feel isolated. And there's a lot of touch points and there's a lot of engagement to make sure that you feel part of the community and that you can study in a remote environment but feel part of a team, and I suppose be motivated in that way. You have the course management team, technical support and individual support as well. The technical support are usually hugely underutilized because the environment just works, and you'll find it very easy to navigate. In terms of entry requirements for the programme, you must have a bachelor qualification in a medical or health related science degree, and you must give us a degree transcript copy in English if it's not in English originally. It's a personal statement of 500 words as to your motivation for doing the programme, why you want to do it, and you have your employer or academic reference letter from your employer saying you're a clinician of good repute and you're currently employed. And you have photographic ID as well. That can't just be a selfie, it must be a formal ID like a driver's license or passport with your photo on it. As I said, we have around 300 clinicians on the programme every year across the globe, but we very, very much limited the places by time zones. So as I said, places are filling exceptionally fast as we speak. We've just closed with 190 students in Ireland and the United Kingdom, but we divide them into groups of 30 and no more than 30. And so we have very, very few places left in Australia, Malaysia and Japan cohort now, and it's filling fast. So if you are interested, I would encourage you to apply very soon and pay your deposit to secure your place, because we do not go beyond a certain number in every single time zone that we're in. So the programme fees, the most important slide of the lot. And I want to be very, very clear that we charge in euro. We do not charge in Australian dollars. So the Australian dollars are up here just to give you an example of what it is. But the currency, due to currency fluctuations, with so much going on in the world, currencies are very precarious. So this is what it was yesterday. It could be something a little bit different next week. So we charge in euro, and the Australian dollar price here is an approximation. So as we speak, it's 12,500 Australian dollars for the postgraduate diploma, and then it's 7,500 Australian dollars for the Master of Science. We do have an early registration discount that is up until the end of October. So there's just a few days left to, if you want to secure that discount, and that's the equivalent of 800 Australian dollars. So the cost to you with the early bird discount would be 11,700 Australian dollars. And but the Master of Science, there are never any discounts whatsoever. The price will always remain 7,500. Or 4,500 euro. So the deposit we ask to secure your place, to make sure you don't miss out for this intake, is 1,000 euro, approximately 1,700 Australian dollars. And you can pay, we're very flexible in the way that you can pay. You can pay by either by semester, or you can pay in monthly installments, and they're the prices for the postgraduate diploma segment only. But you can pay by monthly installments, which an awful lot of our clinicians do. It makes it easier than bulk payments. So the student experience, we've over 36 nationalities on the programme, 300 students plus every year from across the globe. So you get to learn from a wonderfully international experience. There's 88% student engagement, 100% positive support, positive on programme support and organisation. And this comes from our student questionnaires that we give out at the end of each semester. And there's a 92% pass rate to date, and that is not reflective on us being easy markers. It really is a true reflection on the dedication of the participants on our programme. They're working professionals and understand just how important it is to do well on this programme for their own benefit. So the summary, there's 12-month PG Dip, and then the 20 to 22-month Master of Science. The next intake is the 29th of November, as I said, so not long to go. And you get your award from a top 10 UK university, 62nd in the world, and we have very limited places. So if you are interested, I would suggest that you apply now so you don't miss out for this particular cohort. So we'll stop there. And just if you've any questions, now is the time to pop them through on chat. I know, Ralph, we had an earlier one from Farzana, and she was just saying that she had a particular patient, I think, who was asking about the chance of healing in diabetes. I obviously did say to her, I replied that there's no cure, but with the correct intervention, you can go into remission. I don't know if there's anything particular you'd like to add to that.
I mean, look, it's fascinating when you start looking at the data worldwide. You know, you've got your program over in England using the very low calorie diets. You know, in highly selected groups,
Yeah.
But for that highly selected group, it seems to work. And of course, we've now, there's data around early intervention, even with insulin, putting people into remission at a very early stage. But really, at the end of the day, it's going to be around lifestyle. I think things like, the early intervention with insulin and, with the very low calorie diets, you've still got to be able to move forward with it. Of course, we haven't even mentioned bariatric surgery, which again is a really interesting field. But at the end of the day, it's looking at individuals and seeing what's right for the person in front of you, and we can't stress that enough.
No, I think what you're touching on there is absolutely right, Ralph. It's about sustainability. If you put someone on like the direct study, which had milkshake diet, 800 calories a day, yes, their body weight is going to crash and it's going to do all sorts of things. The question is, like any type of kind of fad diet or really strong intervention like that, is that sustainable 2 years later? And that's the question mark. And the piece on bariatric surgery, if I look at countries in the Middle East that we'd be in a lot of the time, the threshold for bariatric surgery in Kuwait or Qatar is much lower than it would be in Ireland, UK, or Australia. They do probably 10 times the amount of bariatric surgeries. And again, it's, what's the long-term evidence base of that going to be? But you're right, it's all about the patient in front of you. And from what from the debates that we've seen among our tutor groups and among our student groups, a lot of it can hinge on encouraging your patient towards a healthier lifestyle and having I've used the word toolkit a few times, but knowing what the techniques are that are likely to lead to them being more ready to make those changes, and understanding what the barriers to those changes are and why they'll resist, and helping them. And then, as you say, if you get something that is long-term and sustainable, the sense of achievement that you get from that is enormous. And
but I'll put the cat amongst the pigeon. Of course, once they've got diabetes, I'd say, well, as clinicians, we've probably missed the boat, because we should have picked them up 10 years earlier and started working then. And so, I'm very fortunate to work in Victoria, where we have a diabetes prevention program that I can refer people to. So we're actually starting the whole intervention much earlier, which of course makes more sense.
Absolutely. And it's funny, the module 1 of the program for the last 2 years, what we've gotten people to do is their first assignment of the program is critique the diabetes prevention strategy in their region, look at other regions, what could you learn and how could it be applied where you are? And Ireland doesn't have a diabetes prevention strategy. We have a diabetes problem, but we don't have a prevention strategy. You've got countries, again, I'll say Kuwait, they are now pouring millions into diabetes prevention because they know the scale of the problem that they have. So yeah, it's absolutely, by the time you've got that diagnosis, you're reacting.
Yes. And you should look, of course, for the low-hanging fruit and Indigenous populations, for example, in Australia, where the prevalence is so much higher. What you can do in terms of early intervention and prevention in specific Indigenous populations can have a huge benefit to long-term outcomes. So it's really important to try and get the low-hanging fruit and to hit them early in terms of prevention.
Can I ask the group then, are there questions about, program structure, eligibility, fees, timing, anything like that you want to put on the chat function for us to answer? We, as you probably guessed, we could talk around this stuff for hours and hours, but I'm conscious we're here to answer your questions.
Very quiet today, but that's okay. Some days we're absolutely inundated with questions. We'll take it as a good thing that we've answered a lot of them with the presentation so far.
Yeah, excellent, clear presentation, guys.
Just to let you know, guys, that this is recorded and we will send out the recording again for you to review. But also we have a team that will be reaching out to you by voice by telephone to just make sure that you have digested all the information. If you want to proceed to application and deposit payments, they'll talk you through that process. So you'll be getting an email from us with the recording and also a button to apply and a button to pay your deposit, and also a call from one of our team. And they will just chat through the program again with you and answer any additional queries that you might have.
Yeah, I think I just finish up by saying, you know, it is a significant undertaking. You know, a qualification like this will take time and effort and energy, but what I hope you've picked up from today is that, you know, it's done with a good humor, fun, it's accessible. You'll meet a whole load of people in similar scenarios and that have quite different perspectives, and that, as Jackie said earlier, you know, that camaraderie and that sense of team and bonding is really important. That, you know, you won't be going through this alone. There's huge support from the tutors, from the program management team, and, you know, it's a really nice experience. So I am biased, but
I don't think you're totally biased, because we do have this thing called the NPS score, and I'm sure you don't know what that is, but it's the Net Promoter Score, which we ask our students, would you be willing to, I suppose, recommend this program to your colleagues and friends? And usually an NPS score around the 20 or 30 is considered exemplary, and for this program it's in the 60s. And around 16 to 20% of our students come from referrals from former participants on the program, and that speaks volumes about just the satisfaction of every single student and participant and willingness to recommend it to their colleagues. So I think it's a great thing to see.
yeah, absolutely. Okay, will we wrap up? There's no more questions coming in on chat, so I think, you know, the guys will reach out. The recording is there. We're really happy to take questions over email, or, you know, you'll be talking to the team anyway. And we'd love, you know, we've got a group of Australians on the program at the moment that are getting on fantastically well, and we'd love to see more.
Right.
So Ralph, thank you so much for your time.
No worries, all the best.
Really, really good
Jackie.
input as always. So yeah, have a pleasant evening, everyone. And
Take care, guys. We hope to see you on the program soon.
Yeah.
All right. Good night.
Thanks so many, guys. Night.